So hello and welcome. This is the I3 session, Uninvited, insight into microbial contamination, embryo toxicity, batch variation in media, and much more. All those uninvited guests that wreak havoc with our IVF life. I'm joined by two co-hosts today. The first, Edel Roche, is a scientific product expert at IMT Matcha. She's been working as a clinical embryologist for more than 7 years around the world. She did an internship when she was 21 in a public hospital in Italy, learning the basics of reproductive medicine and science, then started training in Ireland, and then continuing her work in London, which is where I met her. So over to you, Edel.
Thank you, Giles, for the introduction. You actually need no introduction as an accomplished embryologist, clinical manager, and teacher, who just happens to be executive director of this great webinar platform, I3. We are also joined by Yaren Yilancilar, which is an embryologist at Ventus IVF Center with a keen interest in clinical and laboratory quality management. She holds a bachelor's degree in molecular biology and genetics and a master's degree in human-assisted reproductive technologies. And she initiated her professional career as a junior embryologist at Vita Altera IVF.
Thank you for the lovely introduction. Let's begin with a very distinguished embryologist and fountain of knowledge. Kimball Pomeroy is the Chief Science Officer for IV Fertility. He has worked in reproduction for over 40 years and 30 years as a clinical embryologist. He has written research papers and chapters dealing with COVID-19 and the IVF laboratory, best practices for nitrogen storage tanks, risks of cross-contamination of microbes during storage of tissue in liquid nitrogen, embryo morphology, and the source of microbial contamination during embryo culture. Prior to IV Fertility, Dr. Pomeroy served as the science director for the World Egg and Sperm Bank. He has served on the SART Executive Board and is a founding member of the Southwest Embryology Summit.
Thank you so much, Yaren. I'd like to thank the sponsors for allowing me to present this short presentation to you today. And I need to thank my collaborator in a lot of this, who is Dr. Michael Reed of the Fertility Center of New Mexico. I want to tell you one thing at the opening of this. Don't hang on to every word that I say. It's not they're not necessarily true. As I found, trying to ask myself what is truth, it's ever changing. It's whatever we have the most data for and the most reliable data at that time. I remember the book, The Black Swan, talks about everyone thought that swans were white. And that was true to these people. Then someone visited Australia and they saw a black swan there. And all of a sudden, the new dogma became swans are black or white. So I'm going to present some ideas to you, and I hope you can use this in the management of your labs. Here are a couple of embryos. I don't know if you can tell, but these are not human embryos, but they are contaminated.
Kim, we can't see your slides at the moment, so if you want to just go back there. I thought you were doing a great monologue, and then you're going to dash into your slides. But if you can see the slides.
Let me get back here. Okay. Oh, I see. You have to press that other button there that says share slides. Okay, can you see it now?
That's perfect. Great. Thanks a lot.
Okay, thank you. So here's some bacteria that have contaminated a culture of embryos. Now, I remember one of the scariest times that I had was one day I was checking embryos. I believe it was on day 3. And I began as a human embryologist in 1991. And I didn't have my first example of contaminated culture until 2009. I went in to check and I found a patient that had this rust-colored debris in embryo cultures. And the embryos looked like your typical burnt cinders. where they were just very dark and granulated. So those were probably dead embryos, and there was no way to rescue them. I checked all of the dishes and did not find it in any other patients, nor did I find it in dishes that had no embryos from this particular patient. It was only found in dishes that contained embryos. I quickly isolated all the media for testing so that the media or dishes would not be used until they were verified as not being the cause of this contamination. I removed the media from the affected cultures, as well as media from the sperm pellet and from the wash for the sperm. And I sent them off for culture and sensitivity. And the results came back that they were positive for Ralstonia, and they were traced eventually to the cryovials of frozen sperm, of which, fortunately, I had not frozen. But they were resistant to gentamicin, amikacin, and tobramycin. And these are all aminoglycosides types of antibiotics. So this started really getting me, well, I should mention, we did save this cycle, and we did it by doing another testicular biopsy. And back in these days, we had penicillin and streptomycin in our cultures for culturing. And so what we found out very early on using those two antibiotics is that penicillin had a very short half-life when it was at 37 degrees centigrade. And a lot of times we were putting our embryos in a system for selection of penicillin resistance. So this got me thinking, do we have variability in IVF outcomes? And could this be due to contamination events? And maybe contamination where you don't see a flocculant. It may be contamination, but it's not a high enough concentration to see little bacteria. Also, can viruses affect our culture? What are the primary sources of these contamination events? How easy is it to contaminate our cultures? And does gentamicin, the common antibiotic in our media, protect cultures from contamination? This experience got me thinking along the following lines. Do we have variability in IVF outcomes due to contamination? Now, we need to remember that our air has a lot of microbes in it. And how easy is it to get contamination from the air? Our skin snows with microbes. These guys, whether they're bacteria or fungi, that they're everywhere. How easy is it to get contamination from the air? Well, Dahlstrom et al. Did a study where they opened 45 sterile trays and they left them open or covered. And afterwards, they measured the levels of bacteria in the cultures. And they found out that 3 of the 30 opened trays, the sterile ones, became contaminated immediately after opening. And after 4 hours, 30% were contaminated. And it didn't matter if there was a lot of traffic going in and out of the OR or not. But the towel-covered trays did not get contaminated. So obviously, in this situation, it's fairly easy for microbes to fall from the air or from our skin potentially and get contaminate our cultures. I did a kind of an unofficial survey at an embryology meeting once and asked embryologists what their experience was with contaminated culture. And as regards occurrence, 16% saw it once per year, and 60% or more saw it less than once every 3 years. And 40% have seen contamination of cultures 5 times in their life. When they reported what were the contamination events, it was split equally between bacteria and fungi. There was nothing reported for viral. That's because we don't test any of our cultures for viruses. And viruses usually don't have something overt that we can see, like flocculation. Now, there was a study that was done by Pettit et al. In Ireland in 1996. And They looked at the last 6 years. Another study was done by Castrop in 2007. And then one on yeast was done by Ben Chetry in 1996. And they found one contamination event on an average every 150 to 200 cases. Well, that means most of us should have one contamination event per year, but I doubt that we really do. Why don't we? The reason we probably don't is because these were all done in big box incubators, and a lot of them were probably done using just penicillin and streptomycin as an antibiotic. So Cattell, as I mentioned, did 30 IVF cycles, and this was a prospective study. And they had penicillin and streptomycin. They swabbed the vagina, and then they did 1 punch per ovary to look for bacteria in the ovary. And they cultured for bacteria at different stages. So this is a culture technique, which is not all that sensitive. When you culture bacteria, there's some bacteria that will not grow because you don't have the right conditions for them, as opposed to the more current techniques of looking at ribosomal RNA to determine what is in there. The results of this study was 50% of the cycles had some form of contamination without observing flocculation. 13% of the semen specimens were positive for bacteria or fungi, and 27% of follicle aspirates were positive. When they looked at the primary culture, 7% were positive 20 hours after insemination. So in that time with those systems, it was a fairly common event. So let's look at the possible source of this contamination. I think one of the major sources is semen. You know, we kind of think of semen as being sterile, but it is not. Cattell found it in 63% of semen specimens. He found some sort of contamination. 16% of these men had elevated leukocyte concentration, which may indicate some sort of ongoing infection, maybe prostatitis. Most of these were non-hemolytic streptococci and Staphylococcus epidermis. 14% had ureolicticum, and 4% had Mycoplasma hominis and ureolicticum. So 5% were positive after collection and after a swim up. So the swim up did not stop the bacteria from being moved in to the insemination dishes and consequently into the culture dishes. Now, as I mentioned earlier, lack of evidence does not constitute evidence. So we can't rely on all of these studies that were done a long time ago. But we can see there is a large number of cases and cycles that are contaminated, and you can see flocculants, but there's many clear cultures that I believe also may be contaminated and may be affecting our outcomes. Here is another analysis of contamination. This is retrospective from 14,000 IVF cycles. This is done by Castrop in 2007. They found a 0.7% incidence, which is about 1 out of 200. None of these were with ICSI. Penicillin and streptomycin were used, and sperm were prepared on 2-layer column and usually with a swim up after it. They washed the vagina with sterile saline. When they did this, E. coli was the most common contaminant, found in 60%, and 73% of these that had E. coli were resistant to penicillin or streptomycin. So they also found that 91% of all bacterial contaminants had antibiotic resistance. They found yeast, candida, let me go back here, in 25% of specimens. 41% were detected at fertilization check, and 59% of contamination events were detected when they changed media at day 2 or day 4. And we should remember that penicillin, its half-life is only a few hours at 37 degrees centigrade. whenever bacteria was found in the cultures, they had poor embryo quality, but yeast didn't appear to have an effect on the embryo quality. And that's probably true in most cases, although it can starve the embryo of constituents that it's using for its metabolism. Now, since this group switched to gentamicin, they only found candida contamination in their cultures. And of course, gentamicin is not going to have an effect against a fungi. As I mentioned, there's no contamination in ICSI cycles. The major source was semen. Air didn't appear to be a source. And maybe that's because of the oil that's protecting it. But most likely, we can eliminate lab air as a source. And I remember an argument that I had with one embryologist who felt that embryologists were just sloppy in what they were doing, and they were the source of contamination events. I don't think that's true. How can semen be a source of contamination? If we look for bacteria, a study done by Moretti showed that 30% of men had bacteria in semen. Almost all men had anaerobic bacteria in semen when Egert Cruz et al. Studied semen. Another study by Kiesling in 2008, bacteria was found in 65% of men's semen. Some cases, there was more bacteria in semen than there were sperm. And we should remember, as relates to viruses, which we don't screen for, we don't measure them, herpes virus was found in 83% of men's semen by Neophyto in 2009. Now, this was not necessarily herpes simplex, but was other types of herpes too, such as cytomegalovirus. So one study was done about transferring of embryos that were exposed to yeast. I would probably have a hard time doing this, but they had 0.7% of cases with yeast. There were 5 cases. The embryo quality was normal. And all 5 patients that they transferred the embryos that were contaminated, they all conceived. To me, this is one of the breakthrough pieces of research that was done by a group in Australia, Pelser and Knox. They looked at 263 women undergoing IVF. So this is a prospective trial. All of them had bacteria in the follicular fluid. And then they also looked and found that 71% had organisms that were cultured from the vagina, not surprising. And there they felt that contaminants may be introduced into the ovary when a follicular aspiration is done or an embryo transfer. So that's why you can find so much contamination in aspirations or at embryo transfer. They had a lower pregnancy rate when they found the same bacteria in the vagina or uterus as related to the type of bacteria found in the embryo transfer media. They found that the antibiotics in media was not sufficient against all microorganisms. For example, gentamicin. It's usually mainly effective against gram-negative bacteria. They would look to see if bacteria was the same in the vagina, and they found half of those follicular aspirates had the same bacteria in the vagina, and 25% had unique bacteria in follicular fluid from the aspiration. So that they assume may have come from the ovaries. Now I want to talk about one thing that bothers me a lot. I call it the stealth disruptor. This is a microorganism that decreases cell growth, causes shift in the pH of media. It depletes cell substrates that an embryo can use for, or other cells can use for their metabolism. It induces oxidative stress. It produces ammonia. It secretes harmful metabolites, and it modifies DNA, RNA, and protein synthesis. It can outnumber a cell 1,000 to 1. You can observe it with a light microscope, and it's not a virus. It's pervasive. Half of all women in one study done by Idris had this bacteria in them. And I'm obviously speaking about mycoplasma, which is the smallest living organism known. It can pass through a 0.22 micron filter. So we probably have it in a lot of our media. You have to use 200 micrograms per milliliters of gentamicin to make it effective. And I think most of our media, someone can correct me later if I'm wrong, has about 10 micrograms per milliliter of gentamicin. And it doesn't show any overt signs when it's infected a cell. Now, I wanted to see how easy at one time it would be to infect a culture. So I used disposable 100 microliter Eppendorf pipette tips. And these are what I was using to contaminate. I would touch them for about 3 seconds. And I would touch them on the microscope surface. I would touch them on my skin. I would touch them on the ultrasound probe. And then I would have 5 drops that were covered with oil. And I would put those pipette tips in and touch those, swirl them around. And then I would culture them for a week. I found no visible growth in any of my intentional contaminations, except for a fungal contamination from the ultrasound probe. So it's not that easy to contaminate our dishes. That's probably why we don't see it very often. But that's mainly just looking, not for is there bacteria in there, but is there a flocculant being produced? What about viruses? They have unknown effects. We know that HPV can alter sperm motility. And we know that 83% of 172 men had herpes DNA, HHV6, Epstein-Barr virus was 40%, and cytomegalovirus were 56.9% found in semen. So what do you need to do when you see something like this? You need to determine the source of the microorganism. That's the most important thing. You don't want to keep on using that media or those plates that might be contaminated. You immediately should lock down anything that was used in that cycle and mark it as susceptible. Then you should send off a culture and sensitivity of the media or some media that's been placed in a dish. And you want to determine the antibiotic susceptibility of the microorganism. I know that this is difficult sometimes because hospital labs don't want to run something that's from a tissue culture dish. So you'll have to work that out with them, or you'll have to outright just not tell them what they're looking at. The next most important thing has to happen at a contamination event. You have to be open about it. You have to have a quick communication to the physician, quick communication to the risk management, and then as quick as possible, have an honest communication with the patient. And they should understand that in most cases, these come from the semen. Don't toss anything. Collect all your primary sources, as you see here. One of ours was a cryogenic vial, was one that we found. And then you could look at cryopreserved sister vials, or sister dishes, or dishes that didn't have sperm added to them, or dishes that didn't have embryos in them. And look at your secondary sources, the contact items, your plates, your sera, your media. In summary then, overt contamination occurs in about 1 every 150 to 200 cycles. It's probably less often now. The source is almost always semen or follicular fluid. Follicular fluid and semen are not sterile. Most common contaminants are yeast, E. coli, mycoplasma, and staphylococcus, and most are antibiotic resistance. Thank you very much. I will now take you back to the moderators.
Thank you so much, Kimball. Just an interesting presentation. I actually loved it. So now it's time for a question. So I actually found one really good question here. How to handle this kind of contaminated samples. So I have a question that comes with, if you have an infection in a droplet with an embryo, what will you do? Will you still transfer it? Or will you freeze it first and then test what contamination is it? Will you actually discard it? What will be the future of that embryo?
You know, that's a tough question. I can tell you what I would do. I know many people will transfer ones that are contaminated with yeast because of a small study of 5 people. I wouldn't transfer any of these. You can wash them out so you have no more flocculent. You don't have any more yeast particles around, but you don't know what is in there microscopically, and you might cause a tubal infection. To me, that's the worst possible thing that you could do, is cause a internal infection of your patient. So I would not transfer any of them. I would not vitrify any of them. If you are hesitant about discarding them, then at the very least, vitrify them and make sure you mark them that you need to have serious discussions with the doctor and patient.
Okay, thank you very much for the answer. It's really clear to me. So now it's an honor to introduce our next speaker, which is Matt Pettit, by a tool sponsor by IMT Matcher. Yay! So Matt is the Chief Scientific Officer for Matcher Technologies, responsible for development and implementation of Matcher, which is a barcode-based electronic witnessing system. Since gaining a degree in biology at the University of Wales, Matt has worked in the field of assisted reproductive technology, leading bovine breeding companies and cryo-storage facilities. In addition to this magnificent career, a fun fact, Matt is also a trustee and scientific advisor to Nature Safe, a new initiative working in collaboration with the World Zoo for the long-term storage of live cells from animal species that are at risk of extinction.
Thank you very much, Edel, and thanks, Giles. Thank you, Yaren, for moderating yet another excellent I3 session, and also thank you to Dr. Pomeroy for his fascinating yet gruesome presentation on bacteria. It just goes to show that being uninvited doesn't necessarily stop you from joining the party, so there's hope for me yet. Here's my declaration of interest, just to get that out of the way. I'm employed as the Chief Scientific Officer for IMT Matcher, who provide electronic witnessing, traceability, and data insights. The phrase lions and tigers and bears, oh my, comes from the 1939 film adaptation of the classic book, The Wizard of Oz. And in the movie, the protagonist of the story, Dorothy, along with her companions, the Scarecrow and the Tin Man, chant this line repeatedly as they venture through a dark and frightening forest. This moment in the movie highlights their vulnerability and the hazards that they face on their path, the yellow brick road. And the chant symbolizes the characters' fears of the unknown dangers that might lurk ahead. Acknowledging the topic of this session as uninvited, I intend to use the metaphors of the lion and the tiger and the bear to represent 3 topical hazards and their associated risks that we know from research instills fear and anxiety in IVF professionals. My talk today also aims to consider some of the ways in which you can mitigate these risks and alleviate some of the burden of responsibility and liability on your yellow brick road or journey to implement and enhance best practice and total quality management. We know fear exists amongst the industry because as a developer of a quality management system, we frequently ask you. The aim of the most recent survey conducted by us earlier this year, for example, was to firstly gauge the level of concern within the profession, and secondly, to ascertain the perception of electronic witnessing systems introduced to mitigate these concerns. And 68 out of the 77 respondents expressed concern about making mistakes, especially when performing laboratory procedures. And an emerging body of research supports this. And that research will often refer to the current occupational challenges in relation to human factors that usually sit at the root cause of these errors, which agrees entirely with the top 3 reasons provided for why mistakes happen in response to our survey, those being stress or pressure, distractions, and fatigue or tiredness. And 43 of the 77 professionals surveyed also felt that their ability to perform some of their duties had actually been compromised at least once in the last 6 months because of these human factors, which of course poses a risk to their own safety and to the safety of patients and their gametes and embryos. Therefore, perhaps it's time to take a look at ways in which quality management systems can be enhanced to alleviate some of the burden of responsibility and fear felt throughout the IVF profession. Perhaps it's time to confront our lions and tigers and bears head on and assess the associated risks to implement control measures to mitigate these. So without further ado, let's begin to explore some of the most relevant uninvited hazards that exist today in relation to your world of assisted reproductive technologies. What are your lions and tigers and bears? What are their associated risks? And how do you even begin to confront these risks head on in a bid to conquering your fears? The hazard we're going to address first is the lion, or in your case, lot recall. The industry were recently reminded that uninvited issues do occasionally arise with quality control procedures relating to consumable medical devices like media. And this will be referred to, I think, in the next presentation. In December last year, there was an urgent voluntary recall of 3 lots of embryo culture media and a recall of mislabeled vials of a single-step media. But this isn't the first time it's happened. There have been other instances, such as specific lot recalls of IVF culture oil in 2012, biopsy media in 2022, a vaginal pessary also in 2022, and a cervical dilator in 2020. And in January 2018, the MHRA issued a medical device alert relating to 145 individual lots from 48 media products that were subjected to increased histamine levels in the common antibiotic used across all of these media. The risks of product recall were acknowledged and incorporated into the EU Tissues and Cells Directive 20 years ago. This legislation is enforceable across the whole of the EU, and it could be regarded as a benchmark or best practice for the IVF industry globally. It stipulates that all relevant data relating to products and materials coming into contact with tissues and cells, which includes gametes and embryos, must be recorded and can be traced. And as we've observed, the requirement should not be considered as a mere box-ticking exercise to satisfy the regulators. It's a vital component of your internal quality system because it links directly to staff and patient safety. We've seen the consequences, which, just like errors in misidentification, lead to personal tragedy, complex litigation for both the manufacturer and the end users, huge financial expense, and reputational damage. And we know as manufacturers ourselves that the risk is increasing. In healthcare, for example, generally, there were a total of 252 medical device recalls in just the first quarter of 2023. And that represents a 5% increase in lot recalls compared to the previous year, highlighting a requirement for improvement in quality control. To some extent, though, the QC that manufacturers of medical devices apply is outside of most fertility centres' controls. But what you are firmly in control of are the risk management strategies and systems that you implement for internal compliance. And this always begins with a robust risk assessment and standard operating procedures that can be implemented, tested, and followed by all, including standardization across a group of clinics or even across the whole industry. This is the best practice model. For instance, a robust lot recall SOP would involve swift action in the event of an alert. This includes answering all of the questions you can see here very quickly and immediately. But how on earth can you do this? I personally don't believe manual entry of lot data makes this even possible. We've seen from our own studies that this takes a very long time. It's too long for it to be effective, and the results are often inaccurate. To be effective, we must capture data digitally in real time at the point of performing a procedure for that data to become useful. For some tasks, even a digital EMR doesn't do this effectively because you're often still manually entering data into tables on a PC away from the work area retrospectively instead of prospectively in real time as you work. And this is where barcodes are the king of the data capture jungle. Barcodes offer the perfect solution for lot traceability, and it's what they're designed for. And this isn't exclusive to media. It covers all products and materials as the EU Tissues and Cells Directive commands, including product locations, instruments, staff members, even apparatus. And barcodes are ubiquitous. That means they're already used on almost everything in healthcare. Regarding medical devices, this can be achieved using the globally unique barcodes that already exist on pretty much all products. And using electronic systems, tracking stock inventory and expiry dates can also be automated. So that's two other things that you don't need to worry about. And because the active product lots are automatically linked to the relevant procedures at the point of witnessing, you can answer all of those very important questions almost in an instant, accurately and with very little effort. And using a KPI dashboard, you can also have an insight into all patients coming into contact with a specific lot or lots in an instant. And this includes the storage location of that lot in question, the cycle number, the specific procedures, and these can, of course, be linked to the patient details and clinical outcomes. So using the example we referred to earlier, imagine how long it would take to manually piece together data relating to 145 specified lots. It would be a nightmare. But with a decent lot tracking system, the SOP for analysis of all of these lots could be executed in less than an hour. Okay, so that's the lion taken care of. What about the next primary uninvited hazard, the tiger? Or in your case, T is for traceability. Implementing an effective and comprehensive system from scratch is rather complex, take it from me, and extremely difficult to achieve because of the number of challenges that we face. But this is obvious. ARTs are complex and they're rapidly changing, and it can be expensive too. The cost of developing best practice creates an additional challenge, although I would argue that introducing a better traceability system actually saves considerable time and cost. And it's a mistake to just think about the value of error prevention when considering electronic witnessing. Of course, it's important, but you should also be considering the value of real-time data capture and traceability. This is just as important, and in my view, it's probably more important. Error prevention is just one part of traceability, and a turnkey system for total quality management should provide you with all of the tools that you need to prove and analyze everything that you did with physical evidence, literally at the click of a button. And also, when we think about traceability, it's not just what's happened in the past, but also a record about what should happen in the future. When we think about traceability in terms of it being proactive as well as it being reactive, the benefits of traceability or track and trace become much clearer. So let's work backwards. Identifying exactly what our most important questions is probably the best place to start. And some would refer to these as our key performance indicators or KPIs. This is correct, but I think it could be even simpler than that. A workflow scheduler and an alerts module is a good example of this, and it's a very useful tool in an ART lab because it provides a real-time overview of patient workflow. This is what you said you were going to do for this cycle of treatment, and it allows you to see immediately if something out of the ordinary has happened, or if a task is overdue, or if there's been a non-conformance that quickly needs reviewing. And when you witness a procedure in the fertility centre, it's important to realise that you're not just checking the ID of the patient. In the 8 seconds or so that it takes you to capture a barcode, for example, you're actually capturing a massive amount of immensely significant data, the type of which can be used to answer your most important questions. In some cases, this even includes taking a photograph of all items scanned, and a picture tells 1,000 words. And this allows you to easily answer the most important questions whenever you or the regulators want to or need to. So it's questions like, how many errors have we made this week or this month or this year, and what type of errors were made, and also who made those mistakes and in what location and as part of what procedure. And it's exactly the same questions that would also apply to a deviation from a prescribed SOP. A good example of this is the industry-wide perception of error rate and deviation from prescribed SOPs. There are so far just a few published articles that have successfully analysed data captured from electronic witnessing systems to establish the true rate of error in a cycle of treatment. But more recent studies evaluate a wider range of error types than previous studies. For example, a study of very large data performed recently at Leeds University revealed that out of 415,000 procedures analysed, a total of 2,400 so-called oops moments occurred, which included selecting the wrong dish from an incubator, selecting the wrongly numbered gamete or embryo in a process, or bringing non-matching dishes or tubes into the work area. They're called oops moments because in all cases, the errors were trapped and prevented by the electronic system. However, it highlights the fallibility of humans is likely to be considerably higher than we first thought. And a deviation from an SOP was also higher than expected, running at a rate of 13% of all procedures performed. In addition to errors and deviations, there are other important questions that can be answered more easily with an electronic traceability system combined with KPI dashboards. A great example of how using a system for measuring time between procedures has recently been used as a KPI for helping to drive efficiencies. And this can be found in Leisinger's and Vermilier's excellent research on behalf of the Ovation Group of fertility centers in the USA. And their work successfully demonstrated how the determination of mean time to perform contemporary IVF lab procedures can be used to establish benchmarks which serve as external standards to improve performance and define reasonable targets for growth. And the list of important questions goes on, but it doesn't have to be exhaustive. It's just a case of designing the dashboard that you need to make informed, smart decisions in relation to the way that you work in real time. And it sounds simple. Well, it is when you know how and if you have the right system implemented. And this brings us very neatly to our last uninvited hazard, the bear, or in your case, the biopsy. And as the industry strives to implement a single embryo transfer model whilst maximizing the chance of a successful pregnancy in a shorter time frame with less uncertainty, a pre-implantation genetic testing, or PGT, is undoubtedly having a positive impact on clinical outcomes. But does preferential selection of embryos come at a cost? The number of steps in an ICSI cycle have increased with the introduction of biopsy for PGT. And now, verifying correctly numbered gametes, embryos, or cells in various processes is essential, adding 3 or 4 procedures per biopsy per cycle. This work's also repetitive, and it increases the risk of errors due to norms or involuntary automaticity, where practitioners may become easily distracted from the task. Additionally, analysing specific genetic characteristics of embryos must be done carefully to avoid transferring suboptimal embryos that may not lead to a live birth or could cause genetic disorders. And this responsibility places a significant burden on embryologists to ensure the right patient and the right embryo are selected, as mistakes could potentially have consequences. And there are further risks too. For example, a survey conducted by Caitlin Flynn revealed the average number of biopsies being processed in a single biopsy dish to be 4, with some clinics willing to place more than this into a single biopsy dish. And this creates challenges around maintaining the chain of custody of an individual embryo through the process of biopsy. Flynn also reported that once the PGT results are known about, most clinics surveyed do not dispose of aneuploid or mosaic embryos or even separate them from the rest of the cohort in the cryovessel. And this obviously creates risk in terms of selecting the correct embryo for transfer at the point of warming, especially if there's no electronic check performed at this point, which was true of 95% of the clinics surveyed. So how do we tame the beast and implement control measures to mitigate the risks surrounding biopsy for PGT? The answer to this question comes back to the humble barcode and real-time data capture. Firstly, in the processing of gametes upstream of vitrification, we can utilize the uniqueness of individually numbered and barcoded groups of labels printed on a single label sheet, reflecting the groups of embryos selected as candidates for biopsy. And then you can use these uniquely numbered barcodes to witness and track the correctly numbered biopsies and embryos through the separate processes of biopsy and vitrification, all the way through to validating the movement of embryos into the cryostores. And this includes cases where multiple embryos are being placed into a single biopsy dish. And finally, when the PGT results are known about, the selection of the fate of the embryos can be made. This might be for transfer, for safe disposal, or for demarcating aneuploid or mosaic embryos that must remain in storage for now, but must not be transferred. If the wrong embryo is scanned at the point of warming before it's removed from the cryostores, a clear audio-visual alarm will alert the embryologist that this is the wrong embryo. So in summary, the hardware and software components that make up comprehensive electronic witnessing systems that make real-time data capture, traceability, and data insights possible can now be included in your arsenal of weapons to fend off your uninvited, your lions and your tigers and bears. And this ultimately leads to best practice for safety, and it helps to drive efficiency, which leads to improved outcomes and results. And if implemented correctly, it can even mitigate the risks of error and prevent mistakes. At the beginning of this presentation, I referred to a recent survey, one of the aims of which was to ascertain the perception of electronic witnessing systems introduced to mitigate these concerns and fears. And out of the 77 respondents, the consensus was that having an electronic traceability system reduces the risk of errors occurring during the IVF process. And also there was agreement that having a system can positively impact fertility professionals' mental health as a result. Thank you. I'll be very happy to take any questions from you.
Thank you very much from my own Wizard of Oz. Brilliant. Thank you very much for that fantastic talk. We just have one question for now, but you mentioned that the change in what we think of mistakes. Now, for years, we've thought through Alan Thornhill that it's been about 0.18 or so, this oops moment. But you've got new data, which is almost 0.6, I believe. Is that correct?
That's true, and it's still in agreement with the early studies carried out by the Bridge Fertility Centre, Xavier and Alan. But we're also broadening the scope of what we consider to be an error, and we're also including the errors that are not necessarily carried through the process. So anything where there is a small mistake, there's a fat finger, wrong selection of a patient on a screen, somebody accidentally brings the wrong dish out of an incubator but then realizes very quickly that it's the wrong dish. They're all, as in our study at Leeds, considered to be errors because they're representative of the fallibility of the human. And it's often human factors that are result. So we're not saying that that's the rate of mistakes or errors. What we're saying is that represents the number of times where humans get it wrong. And that's perhaps why we should be considering that replacing the human at some of those points is a much safer way of working.
And what would you say is the most common mistake? Because you've got thousands and thousands of data, you must have collected an enormous amount of, of the way that they flow, the mistakes, the traceability. So what's the most common, would you say? Or just one that springs to mind, perhaps?
I'd have to refer back to the data, but I think selecting the wrong patient, selecting a patient that you think that you're working with, but you're not actually working with, is probably more common than two things that are not matching coming into a work area. But that's also, potentially an error that could lead to, that can be carried through the cycle. So,
sure. Okay.
Yeah.
Okay. Thank you very much, and we'll hear a lot more from you in the Q&A. Okay. So,
Giles.
thank you. It's a great pleasure now to present first time on i3 Lotte Stroebech in a talk kindly sponsored by Arts Media Denmark and IVF Store. Lotte Stroebech is a seasoned professional with over 20 years of experience in media, manufacturing, and IVF, making significant contributions to veterinary and human reproduction. She holds a PhD in veterinary physiology and has an extensive academic and research background, and she has a role as an associate professor. She's founded Embryo Trans Biotech, introducing the first commercial serial media for animal IVF, and later established Arts Media Denmark and Stroebech Media, solidifying her reputation in the IVF media production. Her academic achievements are many, and you'll hear about them a bit later. You can read more about her from the website we have. And she's done over 300 IVF laboratories globally, helping them guide them into best practices. So her leadership roles on international committees highlights her commitment to advancing ART. So it's a great pleasure to present the last talk by Lotte. Thank you.
Thank you very much, i3, for the opportunity. Thank you, Giles, for the nice introduction, and to my co-speakers, thank you for some really nice presentations. I look forward to the discussions afterwards. Uninvited, I'm supporting the environment with the severe weather that just started with thunder and rain. Right now it's quiet, but you'll know where the noise is coming from. It's unintended and uninvited, but it matches the situation in the talk tonight. So my title today is The Role of Embryo Assays in Ensuring Media Manufacturing Quality. I'll also start by getting my affiliations and conflicts of interest out of the way. Like Giles said, I have many years of IVF and media manufacturing experience. I was, together with Dr. Avery, the first in the world to commercialize a serum-free and ready-to-use IVF media range for veterinary use. I am the CEO and CSO and co-founder of Arts Media Denmark. I worked 6 years at Origio Cooper Surgical when it was in Denmark. I established and was head of the bovine IVF research lab back then. I have board positions at the chairman of the Danish Society of Reproduction Fetal Development. I was on the board of IETS and AETE. Today, Arts Media was founded 4 years ago. Majority owned by a range of fertility clinics doing 50,000 cycles annually. We have FDA approved and available at IVF Store, a one-step culture medium with a new SSR. We have our viscosity oil, sperm gradient, and in application process, semen wash, oocyte aspiration, maturation medium. So that's who I am and my affiliations. My aim of the talk is to highlight the use of embryo assays for uninvited events, obviously for media manufacturing, but embryo toxicity in the lab and in quality control procedures. This is a picture of bovine blastocysts on day 7, and you'll find that my heart lies with bovine embryo assay as the most valid one to test and evaluate performance of media, plastics, whatever you introduce into the lab. So the mouse embryo assay is required for any assisted reproductive technology device that you are releasing. So there are guidelines. We are monitored by FDA through notified bodies. We show in audits our books for quality control, and every single product has gone through numerous tests along with the mouse embryo assay as a requirement for every single release. The MEA test protocol, to summarize, is you obtain 1 cell or 2 cell embryos from sacrificed in vivo fertilized mice. A minimum of 21 embryos should be used in the assay. You include a control group using a medium for embryo culture during the ART procedures, following the same procedures as the test group. Culture embryos for 96 hours, 1 cell, or 72 hours for the 2 cell. And the MIA acceptance criteria is that more or equal to 80% of the embryos developed into expanded blastocysts. There is a guidance for industry and Food and Drug Administration staff on this as well. So the bovine embryo assay, a BIA test, I call it, versus the mouse embryo assay, the test method is that the BIA test uses the same method as is described in the FDA guidance for MIA testing, only with 3 major differences. The bovine oocytes are in vitro matured and in vitro fertilized versus in vivo matured fertilized zygotes from the mice. The second big difference is that the embryos are kept in the medium for 7 days or more in the bovine test. In the MIA test, it has a duration of 5 days if a 1-cell system is used. And third and last, the BIA test uses approximately 200 inseminated oocytes in 2 to 3 replicates, whereas the MIA test requirement is 21 fertilized mouse oocytes, zygotes per group, and just 1 replicate is required. So that is obviously the first huge or the biggest difference. And here is from slaughterhouse obtained immature bovine oocytes for a BIA assay. So the BIA test protocol is that you collect ovaries from slaughterhouse cows, and then in the laboratory, the oocytes are aspirated, all follicles larger than 3 millimeters. You get approximately 8 oocytes per ovary. They are subsequently matured, fertilized, and cultured. And post 7 days, culture, blastocyst rates, and kinetics and morphology are evaluated, as well as hatching rates. And I'll get into that system, how we do that later on. So the average blastocyst rates in the BIA test is between 35 to 45%. It thus indicates a performance difference, whereas 80 or 90 or 100% blastocyst rate in the mouse embryo assay, it'll only indicate whether the medium is toxic or not. I'll give you an example later on. So the conclusion on pass, fall, or fail criteria is that in the BIA test, the blastocyst rate must be equal to or higher than the control IVC medium. In the MIA test, the pass criteria is equal or above 80% blastocyst rate. So let me quickly run through the protocol. We collect the ovaries, we keep them in a plastic bag so there's no communication of the follicular fluid being diluted with the water. Then we do wash it in saline just before aspiration with a vacuum pump. We aspirate all follicles above 3 millimeters. Here you see the aspiration process. We search for the oocytes. After maturation, we have them looking like this. They are all expanded cumular cells and they all stick together. And you can move 40 oocytes all together just in 1 pipetter of 60 microliter medium. To move on to the IVF and IVC, we have a non-capacitating semen wash. We simply spin down, we centrifuge twice and use that pellet for counting the semen solution of about 300 microliter we get from 2 semen straws. We fertilize with 2 million per milliliter, either in drops or in wells. And after an overnight fertilization, this is what the mature oocyte that in the previous photo were all sticking together. You see the semen has done the work and spliced all the cumulus cells. Denudation now occurs in the bovine, where it's in the human embryology. It's after aspiration of a mature oocyte. Here it's the zygotes that we denudate to get rid of the remaining cumulus cells from here prior to putting into culture. And to quote Dr. Avery, it's not a television show. We do not take a long time to discard oocytes, or we don't from the test. We also don't evaluate a lot. We are processing 200 presumptive zygotes, but you can get a quick indication of whether this is going to be a high or a low blastocyst rate, since we cannot, due to the dark content of the bovine oocytes, we can still get an idea of the fertilization rate by seeing this is almost a 2-cell. This is fertilized. You see a clear perivitelline space. Also here you see a polar body, and here you see a non-fertilized oocyte. It goes right out to the sonar. But to get a true picture and count, you need to do a stain and count the prune nuclei. Then we get 30 to 50% blastocyst rates after 7 to 8 days culture. And the result of the blastocyst, if they aren't used for beer, 50% will become pregnant if you transfer them. So there are huge differences in reproductive physiology between the mouse and a woman, and also between a cow and a woman. The most obvious similarity from a physiological point of view in a cow and a woman is the gestation time, and that they don't give birth to litters like mice. So should a batch variation occur, it'll not be detected in a MEA test, where release parameters is more than 80% blastocyst rate. In the BEA test, however, a different as 35% versus 55% blastocyst rates indicate the two media are different. However, both media will have passed the MEA test. Hence, the MEA is a mere toxicological bioassay, whereas the BEA also provides functional and performance data. So more and more labs are introducing ways to test their disposables and their media. It used to be they would perform MEA embryo assays. More labs are starting to also supplement with a bovine embryo assay. At the end of the day, it should not be necessary if the company, the provider of your art products, are strictly monitoring all the steps and the release parameters. It shouldn't happen that anything is released that is not fit for culturing embryos in. Comparison of embryo developed in human cow and mouse, there are huge differences as well. The oocyte diameter is more equal to cow and human. The start of the zygotic genome activation, time to reach a 2-cell stage, the blastocyst hours, hatching hours, and then implantation days is difficult to compare because there's a total different implantation and placenta formed in the cow. But the amino acid uptake and utilization differ among the species, and mouse embryos being very easy to culture with almost no nutrients at all compared to human and bovine. Also, the mouse embryos are less sensitive to changes in pH. Both human and bovine are more sensitive, in particular fluctuations. And then the strains of mice and the developmental stage. The strains of mice used vary, and the stage of embryo used and the culture conditions employed may also affect the outcome. So obviously a test in the MEA where you use a 2-cell embryo is much less sensitive than if it's a 1-cell, or even if it's the bovine where in vitro maturation and fertilization takes place. This is a lot of data to comprehend. Just to give you an idea how we evaluate in the BEA test, we combine kinetics, morphology, and the blastocyst score provides a much better impression of the effectiveness than looking at the blastocyst rate alone. So this system was developed by Dr. Avery and Professor Greve back in 2004 at Copenhagen University. These are the number of oocytes per week that is done. So these are 2 replicates. These are different kinds of media used. There are 4 groups. And then we, from these oocytes, we count the blastocysts, mark the non-blastocysts for our statistical analysis. And then we for the kinetics, we score 3, a non, expanded, and a hatch, and we grade a poor, a good, and an excellent. Then we put them into the calculation, and this is we get for the same media. So each group of media have about 200 oocytes in each group. The blastocyst rates are 39, 37, 28, or 35. So these three groups all are more or less identical. They are not statistically different. However, commercial medium 2, which is a medium that has passed the MIA test, which is sold to human clinics, I would definitely prefer not to have. I would choose one of these instead. The other interesting feature when you add kinetics and morphology score and the arbitrary score is that though this blastocyst rate is lower than the commercial medium, it still has a higher arbitrary score, and you can see it's due to higher kinetics and a better morphology. Not so much better morphology, but in particular a higher kinetics. And then that being said, higher kinetics is not necessarily good, but there are more parameters to evaluate for your media, for your plastics, for your pipette, whatever disposables you're testing, than if you just have plus 80% blastocyst rate. So reliability and consistency. The final performance is above all demonstrated in the bovine embryo assay test. So in media manufacturing, final control steps are crucial for quality assurance, and standard tests like pH, endotoxins, fungal, and sterility are routine. So it should not happen that you have a media that fungal or bacteria arises from, because there are numerous tests performed before they are released. And again, the MIA test would catch many of these. Then assessing performance is equally important, and I think it's often overlooked, and therefore I really welcome that more and more are looking towards the MIA test. I think I touched upon how I think MIA lacks the sensitivity, and again the huge numbers of different 21 oocytes compared to 900 or more. And then you evaluate both performance and toxicity. So ensuring laboratory safety and quality assurance in media verified by embryo assay testing, it should not be necessary in your clinic that you also have to test your products. You should be able to rely on your supplier. I understand the wish to be in additional control of this. I have seen a tendency that you are looking to the website for the media supplier. When is the most fresh medium? When is the next manufacturing going to happen? And you see, I want from that batch. Some media have 18 months of shelf life, some have 24. This is not a bad thing. If that medium in the last month of its shelf life is not performing equally to its first month, then that company overall has a problem, because it's audited by notified bodies on behalf of medical agencies and FDA, and their tests should prove that the quality and the performance and the tox and all the sterility is maintained. Otherwise, that shelf life could not have been determined correctly. So that is the shelf life. Preservation with glass packaging ensures superior preservation of culture media. There's less VOC, and plastic nanoparticles is a huge thing now being found everywhere. So this is another way you can invite uninvited things into your lab. I put this just recently in my slide, having attended a human conference. Media that's been aliquoted for 1 hour to a plastic vial will give a significant decline in blastocyst rates in the MIA test. So do not aliquot. Consider these SOPs if you have SOPs leftovers from when there were bad oil batches, or you had to wash the oil, or is it just a leftover? So consider changing this and get media from glass. But this was a very interesting finding that we did. It showed in the bovine test. And then to change from using the media with the shortest shelf life, you will avoid inviting trouble into your lab if you use a longer shelf life, because there are good witnesses programs, but if these programs could also, if you could talk to each other among the clinics, there is a lot of security that you have a batch that is used in labs worldwide. So if you have a medium that has a stability and a shelf life of 18 months, think of how many other colleagues are using this. And when you have uninvited problems in your lab, worst problem is that you have seroblastocyst or embryo development. The first thing you say is, what's wrong with the oil? The next thing you say is, what's wrong with the medium? And then you start looking to other things. So imagine you could rule out that, because you know you are using a batch that is used in hundreds of other labs worldwide. So the freshness of media should remain consistent between the newest and older media batches within the shelf life. So I hope also with this uninvited that you have a very poor embryo development, that I can invite along with the witness systems, maybe that you can talk to each other and find the assurance in the media you use is being used by many colleagues around the world for many, many weeks. So on behalf of IVF Store and Arts Media Denmark, thank you for your attention, and thank you again for the moderators and for I3 for the opportunity.
Thank you very much, Dr. Lotte, for this insightful presentation. I have a question from Steve Rooks. What is the relative cost comparison between mouse embryo assay and bovine embryo assay? Is there a relative performance to price metric that can effectively compare the two test methods?
That is a very good question that I don't know the answer to. So there are accredited laboratories where you can have your mouse embryo assay test performed. That is a requirement in order to release your product. So obviously for our media, we do that. So we have, since we also have a company providing veterinary media solutions through more than 10 years, we have decided for all our research and development and for the quality control of our media, we have a bovine IVF lab at our facility as well. So I know that more and more labs are looking to do this. If you're lucky to live right next to a slaughterhouse and you don't even have to pay for the ovaries, it'll be a cheap setup to do. I know some places in the US you pay a horrendous amount of money just per oocyte, and then the test is already compromised because the oocytes from the slaughterhouse are shipped maturing on the road. So it very much depends on the setup, but I'm sure in the future we're going to see more bovine embryo assay labs pop up just to provide this service, or that some of fertility clinics also, I know some already, so CCRM have a bovine embryo assay going on. So we'll see more and more of it.
Thank you so much. Now we can move on to our Q&A session. Giles, do you have any question?
Yes, of course, and thanks for a great speech. I think I'll stick with Lotte a moment, and we've got a question here from Don Liger. Of course, he knows a hell of a lot about animal physiology, and I'm sure his questions are valid here. Do you see seasonal variability in your bovine embryo development? Does that happen at all?
Yes, it happens. Especially in Denmark, our winters are really dark. Our summers are very light. So we have, in general, a higher blastocyst rate during summer than we have during winter. But since we have the two criteria we have is if the blastocyst rate is below 30%, we discard the entire test because we consider something went wrong. But if we have 35 in our control, then we benchmark the test medium towards the control. So 35 can pass, and the same media will pass with 45 the following week, because we measure it towards the control group and not a fixed blastocyst rate, because then you would be testing the quality of the cow batch. Because if you have 500 oocytes and you randomize them, you have a pool of oocytes. So obviously the rates will go up and down. So it doesn't make sense to have a fixed blastocyst rate, but just it has to be equal or better than the control.
Okay, thank you.
Answers the question, yeah.
Yes, of course, yeah. Edel, have you got a question?
Yeah, so basically I'm going to read one of the questions to Kimball again. So from Amy Cohen, thank you, Amy, for this question. Given the potential for unseen contamination, would we consider culture and sensitivity of media a reason for embryo arrest?
Maybe I don't understand the question very well, but if you don't see any contamination as a flocculant, I would assume there's always some contamination there. And that's based on coming from the follicular fluid, doing an aspiration. And that is coming actually from the follicular fluid in many cases, and then also from the semen. So I think most of the time we are culturing with some low level of contamination, and we know nothing about mycoplasma.
Thank you for the answer. Next question.
I have a question for Matt. Can you give an example of how the electronic witness system can detect a deviation from SOP? By Karen Bell.
Oh, thank you, Karen. Yes, it's all in relation to real-time data capture. So at the beginning of a cycle of treatment, you would map out your prescribed or expected procedures within the various processes that take place within the various days of the cycle. And then as you're actually performing the procedures, the information is being captured within the witnessing system. So it's recording what you actually did compared to what you intended to do. If you decide to deviate from the expected route, then the system will not just let you do that. It will question the reason why you're deviating from the expected process map. If you're authorized to do so, it won't necessarily stop you, but it will ask you for the reason why. And it all comes back to the value of having the ability to be able to then record those deviations and record that those reasons that are being captured, so that then you can retrospectively output that, and you could then you can turn that into a metric. So you can say this is the number of deviations from the SOP, even by individual user. So you can compare how many times individuals have deviated compared to their colleagues, either within a clinic or across a group of clinics.
Thank you so much.
Thank you.
Giles, do you have?
Yes. Thank you very much. One from a very a popular viewer of ours. This is from Guillaume Barador, and he's asked a question for Kimball. Is there any merit in the continuing use of antibiotics? I presume that's for patients, given the high level of restraint which is now being in clinical use.
Okay, I know the answer to this one. We don't know.
You don't know.
So, no, and I think there's a lot of things that we have to look at. We know that these antibiotics can affect metabolism. So we know that they can become toxic to our cultures, but we don't know the level of those toxins. And as Paracelsus said, everything is toxic. It depends on the dose. So until we know that dose, we don't know, and we could be, in fact, doing more harm than good, but we don't know.
Thank you. Thanks. Edel?
Yep. So my next question is for Matt, actually. So Matt, in your opinion, what do you think is the biggest hazard or challenge in the area of traceability?
That's a good question. I think actually my view has changed in the last 3 years. I think if you'd have asked me that question 3 years ago, I would have categorically said that the biggest risk is making a mistake through misidentification of gametes or embryos. But I think these days, I would say almost a bigger risk is not being able to answer the important questions. With regards to the quality management at a fertility center, for me, it's most important to be able to prove what you did and prove that you've not made a mistake, and demonstrate that you have adequate systems in place for staff and patient safety that shows that you've followed the SOPs and you've not deviated. And if you have the ability to be able to give the reasons why. So not being able to answer questions, I think, is a bigger risk.
Yeah, of course. I agree with that. Any other questions, Yaren?
Can I make a comment on that?
Oh,
Yes,
sorry.
please.
I really think that we have lagged too far behind into what we should be doing. And that, like some countries that I've worked in, this should be mandatory to have electronic witnessing. That it safeguards our patients more than almost anything for the worst problems that can occur. This should be mandatory in the US and every other country.
I would second that.
Totally agree.
Thank
Yep.
you.
Yes, I have another question to Dr. Lotte. Do any clinics use mouse embryo assay in-house or even bovine?
I think you're muted there, Lotte. You're muted.
Sorry about that. I know that it's possible to buy vitrified oocytes and perform your own MIA test. I believe some clinics do, and I also believe I know some clinics do bovine also, and I know the interest is increasing to do a bovine test as well.
Mm-hmm. Thank you. Giles?
Okay, I think I'm going to ask a question from Matt now. Let me just see. I'm doing good one here. Are all barcodes or manufacturers, are they obligated to make sure that they have barcodes that can be read by the same system? Are there anything that we cannot be picked up at?
So manufacturers, most manufacturers are obligated to use a global standard of barcodes or some other machine readable identifier that qualifies their products as being globally unique. And that barcode should be encoding 3 essential pieces of information. Firstly, the product code, secondly, the lot number, and thirdly, the expiry date. Certainly in the UK, it's mandated. I would imagine it's the same for most other geographies, but there will still be some manufacturers who are not using a global standard barcode. But I would estimate around certainly more than 90% of medical device products will be using a standardized, globally unique barcode. So you can make use of those identifiers that already exist.
Okay, thank you.
Should I actually ask my next question?
Go ahead, Edel.
Okay, so another one from Kimball, and I'm done with this one. It's a really easy one. So Kimball, do you think we should wear masks in the lab? Because most people don't do that, and maybe it's a practice we should all follow.
That's a good question. I think we do some things for appearance, and I think those are important things we do, as long as it doesn't interfere with what we're doing. But if you have masks that are fogging up your glasses, then I think that becomes a hindrance to safety. So if you don't wear glasses, there's no harm in wearing a mask. I'd wear a mask. And I should add to Lotte's question about mouse embryo assays, I would bet you over 80% of people in the US, 80% of labs in the US do the MEA in their own lab by the purchase of frozen mouse embryos.
Good answer. I like that.
Yeah, I should
Thank you.
say I would also wear shoe covers. I don't like the sticky things in front of the OR suite or the lab because I think those have the potential of you stepping on it, getting tackiness on your shoe, and then bringing stuff in. But as much as possible, if we can clean up things, even though it's stuff that we don't know that's effective, we should do it. It's nice to have everyone in scrubs, looking nice and neat. That's not how I worked when I was with cattle, but we're not dealing with cattle here.
Yeah, of course. Yeah, I agree with that. Thanks for your feedback. Do you have any other question?
Yes, I have again for Dr. Lotte. What is the main cause of recalls? Why does it happen?
That is a good question, and I also don't know the answer. In 20 years, I've put media to the market. I only had to do a recall twice, and once it was the provider of our oil, and once it was a mistake we made with doubling the amount of amino acids in our fertilization medium for our veterinary. And this is a long time ago. Since then, we have not had to do a recall, touch wood, and I hope I never have to.
Thank you.
But things can happen, yeah.
Yeah, true.
Okay, and I've got a question here by Neil K. DeMonk. This is for Kimball. So, if not all contamination is visible, how frequently should we be testing for our culture media? And again, whether it's also pH or osmolarity, whatever, how diligent should we be?
Well, unfortunately, I don't think much of us are able to do as much of our own QC on our media as we like to. I think we have to depend to some extent on what the manufacturers send us. But I would say with what's happened recently, that everyone should at least have some sort of test on their media. And there are at least 2 studies that I know of looking at specific toxins that indicate that the human sperm survival assay may even be more sensitive than the mouse embryo assay. So as a very minimum, maybe doing a quick culture overnight with human sperm as a bioassay in addition to the manufacturers.
And of course, I suppose in this day of social media, we perhaps hear about this much quicker because, of course, we speak a lot more, don't we? And I think if there's any suspicions, that gets around pretty quickly as well.
So can I add a comment to that? So I agree the human sperm survival test, the bovine bull sperm test is also very sensitive. So we add that also. Again, you'll only have a tox issue. You won't catch if labels were switched from culture to ICSI medium or a Hebus buffered medium. You'll only catch so much, and then it shouldn't really be necessary that you cannot. You shouldn't have to test every media you get into your lab.
Mm-hmm. Yeah, actually, yeah, that's a really good answer. Yeah, we have so many tests that we should actually perform on the labels as well. So I agree with that. I have a last very question for Matt. I'm not sure if you know the answer. I definitely don't know, but I get it's high. So if e-witnessing is not used, what level of error exists? Is it higher by how much to manual witnessing?
Sorry, Edel, could you just repeat the last part of the question?
So basically, if electronic witnessing system is not used,
Oh, okay.
what level of errors exist higher to the manual witnessing or lower?
That's a difficult question to answer because the data is simply not being captured. But we know from the studies that we've conducted and the evidence that we can get from the electronic witnessing systems that humans are fallible to making mistakes. So you would hope that those errors are being captured by the second human, but of course they're also fallible to making mistakes. And often if you've got 2 people responsible for a single task, therefore nobody is responsible for that task. I'm not suggesting that exacerbates the problem, but it's just risk that has been assessed. It's considered that it is a risk, and there are control measures already available to mitigate that risk. So for me, the answer to that question is almost irrelevant. I think you just need to apply best practice where possible.
Yeah, of course. Yeah, when you do manual witnessing, it's really hard to actually like mitigate the errors. You don't know what you have done anyway. You cannot check retrospectively. So I agree with that.
And I would
I should mention,
yes, go on, Kim.
yeah, I should mention that just in the last 2 months, I know of one case where 5 people signed off on the transfer of specific embryo, and all 5 had the information in front of them, and they all signed it off when they didn't check it. So that wouldn't have gotten by electronic witnessing.
No, that's a condition of the human psyche. That we're all vulnerable to that. You know, I trust Edel, she trusts me. I trust Giles. I think he trusts me, or maybe he doesn't.
I do.
but yeah,
it's
the default answer
yeah.
to any question is always yes. Yes, I agree.
And I mean, you know, it's things that we do automatically, as you said, Matt. You know, which of course Toft first, you know, spoke about. You know, do we remember how we, you know, made that coffee in the morning? It's, you know, so much stuff is done automatically. But one thing I've seen with everyone that goes from manual to electronic and then back to manual, it's just impossible to work like that. It's so difficult, you know, because once you've got that safety net, then I mean, you know, it means so much. But I think on that ground, we should start to wrap up. I'd like to thank everyone. Fantastic questions, fantastic talks. I hope you all enjoyed yourselves. I'd like to thank everyone that took part in this webinar, my co-host, Edel and Yaren, and of course, presenters, Dr. Kimball Pomeroy, Matt Pettit, and Dr. Lotte Stroebech. Thank you very much.
Thank you, Giles. I would
Thanks,
like
Giles.
to thank our sponsors today, IMT Matcher, Arts Media Denmark, and IVF Store, and not forgetting the incredible team from i3, the organizing committee of this initiative, who are Jack Cohen, Peter Nagy, Mary-Ann Sebeches, Thomas Elliott, Fran Farley, Violetta Sora, and Giles Palmer.
Yeah, such a great team. So yeah, so please join us soon for the next i3 session, another RBMO live with top papers on Tuesday, 11th of June. So please don't miss it. Okay, bye everyone.
Bye.
Goodbye. Thank you.